Oh, look, I'm standing here and the room is getting quiet. How fantastic. Welcome, everyone. My name is Lisa Dolovich. I'm Professor and Dean of the Leslie Dan Faculty of Pharmacy, and I'm really pleased to be able to start this session, say hello, and get us started for what I know and is going to be a really rich set of presentations and discussion about the evolving pharmacist scope impact on our health system. I want to thank everyone who's here, in person as well as online. I think we have 50 plus or so people online, which is great. We're really delighted that we're able to offer the opportunity not only for fun people to come together and see each other in person, but also for people to enjoy this experience online as well. I want to just start by doing a land acknowledgement, really to center ourselves on the thoughts that this opportunity lets us have when we acknowledge the land. And so I will do that today. I know there are people joining us from different places, and so please do think about what this means to you and where you are. But I will state the land acknowledgement from the University of Toronto. And so for thousands of years, the land that the University of Toronto operates on has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. And in thinking about today, when we're talking about the evolving scopes of pharmacy practice, it means really also, centering ourselves on what does that mean for in our Indigenous colleagues, Indigenous patients, the Indigenous needs that can be met, we hope, by the healthcare system, and all that we want to think about in terms of pharmacist scope of practice to get us to addressing those needs in the best way possible. I'm going to now also talk about some housekeeping issues. If people who are here, this is mainly for the people who are in the room, the washrooms are through this door, and you'll see some signs as you go out the door. There are QR codes. You can see them at the back of the room for the agenda if you don't have that with you. And I just want to thank the students that are helping us, and for any graduate students that are here in the room, there's an opportunity to sign up to get credit for this as a session for graduate seminar. I also want to thank a number of entities because this is a collaborative effort in terms of putting this event on. We are here at the University of Toronto Leslie Dan Faculty of Pharmacy. This is also co-hosted by the Ontario Pharmacy Evidence Network, or OPEN. And OPEN is a team of multidisciplinary researchers working together to evaluate the quality, outcomes, and value of medication management services that pharmacists and other healthcare professionals provide. We like to promote in open knowledge translation and exchange and build capacity in that research while addressing the needs of Ontario's vulnerable populations. And for those of you who were with us yesterday at the Open Summit, it was another opportunity to discuss the research that's ongoing through Open and the venue that the summit provided, and that was, I'll talk a little bit more of that in a minute. This is also hosted by the Network for Improving Health Systems, which is a collaboration between the Leslie Dan Faculty of Pharmacy and the Dalalana School of Public Health. And in this network, we aim to create a strong engine for evidence and knowledge transfer around improving the healthcare system, including evolving pharmacy practice and related health policy. And so for the NIHS to exist, its purpose is manyfold, but the idea that it's not only pharmacy, thinking about pharmacy-related issues, but we're working with colleagues centered in public health and indeed in other places in the university, but to look at the health system and then, of course, think about pharmacists' contribution to it. So it helps, I think, provide a balance sometimes to the conversations that happen in a pharmacy-centric events and entities. So really glad to know, we're really glad to be able to have the NIHS working with us. We have a new website for the NIHS. Just it's great here. Thanks to Annalise for all your hard work and our communications folks for moving this forward. But for those who want to learn more about it, that is our new website. We did have the Open Summit yesterday, so I did want to just share that it was, I think, it was a fabulous event, if we all don't say so ourselves who were there. You know, many of you in the room and those online participated, presented, added to the discussion. And I think some of the key takeaways were that there is a lot of very interesting, impactful work going on in the research space related to pharmacy services, scope, health human resources, implementation, and it is bearing fruit in terms of showing the impact of pharmacists and the contributions pharmacists can make, but also how that can happen. And, you know, what are the implementation issues we have to think about? So there were lots of discussions about health human resources in a broad sense, and what do we need to support the system, the profession, patients, et cetera, in getting us to a system that we can all be proud of and is all doing the work that we want it to be able to do, with pharmacists doing their role or having their role there. So lots of people were presenting. I hope there will be time to bring up some of that in discussion going forward. I did want to go through the agenda for today. We have two presenters from the A team, I'll call them, as of yesterday, from Australia and Alberta. I'm going to introduce them more formally in a minute. They're going to each give presentations. Both Lisa and Ross will each give a presentation. And then we have some project presentations that have been funded by our NIHS initiative. And so we have 3 presentations coming from that funding pool, all very different, I think, interesting, and going to add to the conversation. And then Meena Tadros is going to moderate a panel discussion where we will have the opportunity to talk more about what has been presented and hear from a number of people about their perspectives, and hope that there will be time for conversation and discussion. I do encourage people to think about questions, comments, and there will hopefully be time to ask those questions and have that conversation as we go. So with that, I am very pleased to invite my friend and colleague Lisa Nissen here to give our first presentation. She is the program director for the Health Workforce Optimization Center for Business and Economics and Health. It's a new role, so I'm just getting used to saying that, you know. At the University of Queensland. She's been a health practitioner, a leader, educator, researcher, and implementation scientist in Australia for more than 25 years. Her research has led to major health system change, including the introduction of immunization services by pharmacists throughout Australia and the implementation of prescribing competencies and frameworks for health professions nationally. She is truly a leader. She has changed the face of pharmacy in Australia, along with many people that she has worked with, and we're delighted that you will speak to us today.
Thank you. Thank you very much, and thank you, Lisa, for having me, and the Open Group, and the pharmacy faculty, and everybody here. It's really great to be back in Canada, and as I said yesterday, we've stolen a lot of ideas from Canada and then implemented them in Australia. So they're technically Canadian ideas that we've put into Australia. So collaborations have been very strong with our Canadian research colleagues and have enabled us to do the work that we do, and we hope that we can share some of our work that helps to inform opportunities here. It's a Lisa thing too, so Lisa N, Lisa D, Lisa G, Lisa Mac. I mean, maybe that's a pharmacy practice research thing. So my intention today, it's called Snakes and Ladders and Plunk. I intend to be a little bit, I think, provocative in what I want to kind of talk about with regard to how we do scope of practice work, noting that this is a room who is interested in research and looking at evidence and looking at how we construct agendas that change practice. I'm going to kind of poke a little bit in an Australian kind of way. So my presentation is going to take us through a few things around how we work through expanding scope of practice in Australia, and a couple of the opportunities Lisa's talked about around vaccination and UTIs as an example. I'd also like to acknowledge the lands that we're on today. I come from Yagara and Turrbal country in Brisbane in Australia, and acknowledge elders past, present and emerging, and any First Nations people that are with us today. But also acknowledging that their contribution to society and country are long-standing as our first health workers and indeed our first pharmacists in community. So from a healthcare perspective in our country, and noting from much of the news that we see internationally and within Canada, health system is in crisis. And I think crisis is even a soft word for where our health system might be. And so across our media, our television, our radio and our print media, we very much see headlines like the one on the left-hand side of the screen. And we are having people die in ambulances outside emergency departments. So what that gives us an indicator of is the fact that people are not able to get care in primary care, so in their community, and they are ending up at emergency departments that cannot treat them. So they're stuck. And at the other end of this system, we have our primary care system that's unable to assist them. And the face of that for us is our general practitioner or our family care practitioner. But there is a wide group of health practitioners, our pharmacists, our nurses, our allied health community, who also provide care there. But what we're seeing is not only a shortage of our family care practitioners or our general practitioners, and a number of other health practitioners saying, we can help, we can help, we can help, but also a fatigued and burnt out workforce post-COVID. So the contrast to this is that in Australia, our politicians are saying, well, why don't we use our wider health workforce to lean into this? And that's been an opportunity for groups like pharmacy to do things like minor ailments, things like UTI, expanded prescribing. It started with vaccination 10 plus years ago, but maybe our medical colleagues, our family practice colleagues, haven't been so excited about that. As you might see over on the right-hand side and left-hand side of the screen. So it's pitchforks and fire sticks, and commentary like it's bus drivers driving a plane. So why would you do that? So while we've got a system in crisis where we can't access care, it's very hard for people to get the care they need. We're trying to assist in reforming that. The people that we would want to help us partner in that are saying, we don't want you to help. So it's a really interesting agenda that we're faced with and we're trying to overcome. So our workforce is stressed. We have shortages, we have an ageing workforce, the distribution issues like you would have here. We have a metropolitan workforce. We have difficulty getting people into regional and rural areas for various reasons. There's concerns about whether we're training enough, whether the training is right, whether we're attracting people with our training into the areas they need to be, whether the workforce is supported from a well-being point of view, whether we're putting the right supports and structures in place when they get into a very complex health environment, whether we can retain them. And variously, we know in our workforce, we're losing between 5 and 20% of our workforce over a normalised 5-year period. So we are losing people from the workforce as quickly as we put them in the other end. And there is no plan. Yay. So we have no national workforce strategy. So in contrast to what we're starting to see from folk like yourselves, where you are seeing now a view that we need to have a national strategy around workforce and how you support it, we don't have a plan. So we have the same problems. We're spending more. We have a lot of chronic disease, but we also don't have enough health workers for the population who are going to need the care, let alone workers for the population who are going to need the care. So we are in a pickle. It looks a lot like this to us. For the people that are health service planning, what are we going to do about it? What do we do when we have a complex system where people are pulling single levers at a time and hoping that it will fix what is a very complex problem? And our medical colleagues are saying, well, you can fix it, just pay us more. And we know that that is not going to be a solution to a problem. So expanding scope of practice seems logical, right? That's how we're going to do it. We'll just expand scope of practice for pharmacists and other health practitioners, and that'll be the lever that you pull to fix it. Makes sense. But I say it's like rolling a dice. And it's like a mix of games, not just snakes and ladders, or Plunk, but also a little bit of Cluedo, and mostly Hungry Hippo. So if you think about snakes and ladders, right? So snakes and ladders, if you played it, you start down the bottom, you've got to make your way around the board, you climb gracefully up a ladder until you hit a snake, and then you fall all the way back down, and then you've got to make your way up another ladder, and then you fall back down, you make your way. So that's great, but this is what scope of practice expansion might look like if we play snakes and ladders. So we do practical pilots and trials, or death by pilot, as I like to think about it. You have some small successes, so it's like climbing up your ladders. Progress is slow, right? And it's difficult to get buy-in and consistency. So in Australia, we have our states or provinces like you do, while we have a national funded access in primary care and funding for medicines. We have laws that are based in jurisdictions, and our hospitals are based in jurisdictions. So we have fragmentation of care across provinces or states like you do. So it's difficult to say, well, what happened in Queensland, we can do in another state, right? And so what stakeholders then, or our knowledge users do, is variable in how they engage, because it will depend on what is politically hot or interesting for them within their local area. So the impact often stays locally. So it's what has been politically palatable in their local area, because they're interested in what they can fund or locally influence, because everything else is federally funded. So unless you can get all of the jurisdictions on board, you can't pull the strings at a federal level. So that's the benefit of having things that are broken into littler parts, right? So it's very sporadic that you get large-scale success in that case. Think about Plunk. So this is the other way that things happen, right? And this is probably more what we like to think in our beautiful rainbow kitten research world, right? Where you have all of the balls are sitting on top, and you have the sticks that you pull out slowly. You pull them out slowly. It's like pulling teeth. Am I going to die with this one? Pull it out. And the balls slowly drop through, right? So we do good, practical, evidence-based pilots or trials, or we collect evidence. It's randomised clinical controlled trial, that's cohort study, that's step wedge, that's whatever. We share our information with everybody, and we disseminate it through all our beautiful journals that nobody ever reads. We talk about it at our conferences that nobody ever goes to except us. And we share our data between ourselves, which is great. We lobby with evidence, right? We do lobby with evidence, so we go and we lobby and we share that with our colleagues, right? So as academics, we'll go and share it with our knowledge users in the profession, and we'll say, look, it's really good, you could be doing this would be really great. And they're not necessarily sure, but we show it to them. And it makes no difference, or it has limited impact. And 10 years, 20 years later, I still am struggling to get pharmacists to prescribe. I've been trying very, very hard, but I've helped nurses, optometrists, podiatrists, now physios, and I still can't get my own profession to do it. And it often lacks strategic impact or support. And you're like pulling the sticks out one by one. You don't know what's going to happen. And then it can be like Cluedo, right? It's a murder mystery, right? We do it and we don't really know who the key knowledge user or stakeholder is. We don't know what the resourcing and supports should be. We've got to try and do something that's a real mystery. We don't know what the best place for it is, what the activity is. We don't know what the timelines are going to be for the implementation, or what the best implementation should be. And we don't necessarily prepare and support the profession for it. So it's a mystery. And sometimes that's been because somebody says there's a grant that's available, or here's some money, do this. And you go, we like money, universities like money, we'll take your money, right? So it's a mystery, right? And so it's not exactly how you want to do it. But by far, my favourite kind of implementation is very much like the people over there. I like to call it hungry hippo, or another term is the policy window. It completely lacks strategy, often. The decision has been made based on a lunch that somebody had with somebody, usually a boozy lunch involving wine. Somebody's got a family member, a friend, a relative, a child, or a grandma who has an issue, or somebody is lobbying through a union or something else. Now, sometimes that's been based on a lot of conversations. It's sometimes based on a good outcome that will happen, but the actual window that opens is often because of those reasons. So it feels like you are lurching after those balls on the ground, and the profession sees a window open, and it's got one of those baskets that we just saw, and it is just going, take it, right? So it's like hungry hippo. So the window pops open suddenly. We had a lot of policy windows open during COVID. When the pandemic opened, it's like, we can do that, we can do that, yep, I can do that, yep. We've got some evidence, right? We've got some evidence that pharmacists could vaccinate. We knew that they could do preventative point of care testing. We knew it, so we're going, yep. So we open the filing cabinet, we pull out our evidence that we've collected for 20 years, right? And we go, we've got something that aligns to that, we can do that, right? But there is often little strategy, little planning, and you have to implement it yesterday, right? So the timelines are not often good, right? But we go, okay, you haven't given us enough money, there's no planning, we haven't got an education strategy, we haven't really talked to the profession, we'll do it, right? Because it's a gateway, right? This is the crack for us, because we think this is a gateway to get the relationship, to prove that we can do something, and good will come of it for us. Good will come of it because we can show we can do something. We'll do it as a loss leader, right? We'll lose money on doing this. We'll burn all of our relationships. It doesn't matter, because if we do this, we will get another opportunity. Something will come of it. So 2 examples for you. Our first hungry hippo moment was vaccination. So we had been talking to politicians about pharmacists doing vaccination for years, right? Years. The US had been doing it. You guys have been doing it for 10 years. I'd come back from trips here. I did my postdoc here. I'd said, Ross has been doing it. You know, they're doing it in Ontario. We should be doing it. And they're like, yeah, I don't know. People will die if you do vaccination. Anyway, so what happened was our chief health officer saw SARS happen, and then we had the other pandemic come. Pharmacists were sitting around the table going, yeah, we can hang on to your ciprofloxacin in a large bunker under a stadium if you want, but we could probably do some other things for you. How about we did vaccination? And so our chief health officer had a strategy around vaccination, wanted more people to be vaccinated in the wider community. And we went, we can do that, we can do that. She's going, well, you do know a lot about drugs and you do know a lot about vaccines, but you don't stab people. I said, we can teach people to stab people. She said, yeah, you probably can. And so we were very lucky at the time that we were able to, we could, well, I couldn't, but other people could. We had, you know, the ability to lever a relationship that gave us some training program that we could adapt, and you know, no money, no time, no whatever. So in 3 months we had a program up and running. But Jeanette knew there was going to be another pandemic. So what we learned, international partnerships gave us a quick start. Pilot data that we had from Queensland, it was evidence in action. So our early data that we had from that pilot, we went to all of the other state ministers and health departments. So I literally walked up to them and said, look, nobody died. This is a training course, it's really quick. You could have pharmacists doing this. So we lobbied that, and we did integration into our professional practice really quickly. So we got accreditation standards for unis, and we got accredited training up around the country really quickly. So the profession came on board very fast because we've been nagging them for a really long time, got an IT system in place, and away we went. So the funding policies and future growth came from that. And so we got a national immunisation program access 10 years after we started with our first flu vaccine. And so, you know, we're away now. We can do kids, we can do all the vaccines that are available to everybody else, and it's funded nationally. So the lessons from that is that, you know, advocacy helps, but it's when the policy window opens that you get that opportunity to really lean in. We were able to test regulatory processes and show that it would work. We were able to show that pharmacists could do top-up training and expand scope of practice very quickly. We were able to show that you could use user pay funding models and that people would pay because it was convenient and it was of value to them. We were able to develop software, and we were able to use the fact that pharmacists administered medicines to be able to administer other things. So we've been able to lever off that. Our next policy window, or hungry hippo moment, was UTIs, because our health system is in crisis. We've been able to lever another inquiry, which was into ownership of pharmacy, but out of that inquiry, like, I was able to present to that and say, well, if you're going to have pharmacies and they're really accessible and people come into them, you know, 14, 15 times a year for healthcare, you know, why don't you get them to do other things? And they wanted to keep people out of emergency departments, and so they said, I think you should do a trial about UTI, because we flagged that, you know, that was one of the services that other countries do. So again, it was the relationships that we were able to lever with our Canadian colleagues, our colleagues in New Zealand who'd done this with pharmacists before. We used our pilot data again early and went around and lobbied the other jurisdictions and was able to use IT systems and education and training to uplift across the country really quickly and get the future growth. And similar to vaccination, we were able to demonstrate that benefit very quickly around models of care. And I think the important model of care change here is we've levered it now for minor ailments or minor ailment plus. So there are some chronic disease programs in there as well, and up to 23 plus conditions now for pharmacists. And so what it looks like now from sort of 10 years ago when the first Hungry Hippo opened, so it's not all horrible, right? It is about a loss leader. We did that whole program for Vax for 10 grand, right? I think my dean was like, I don't think I ever said how much we did it for. But from what happened with Vax, you look at it now, we've got UTIs, we've got minor ailment programs, we're administering long-acting opioids, we're doing pharmacist-partnered charting, and it's all around the country. But the note is we've got some things that are common, but some things that are still different and emerging over that time period, because we've got stupid jurisdictions too. And so I think advocating for pharmacist skills and abilities is super important. Trying to harmonise the regulation and legislation and national policy is still a challenge for us, but trying to go and getting the local knowledge users to use the same language and the same asks when they go as is used in other jurisdictions is really important. We've tried to use the same education policies and same funding policies in each jurisdiction, but we've still got a case where if I've trained as a vaccinator in Queensland, I have to do slightly different training in New South Wales or slightly different training in Victoria. I know, it's stupid. You should be squinting. Having software that integrates has been a game changer. Because we are silos in our community pharmacies. As soon as we were able to send our vax data into the same portal as everybody else, it blew open our ability to do vaccinations across a broader range. And we really have been lobbying on the basis of pharmacists need to be wherever there is a medicine. And that's really, again, opened up our opportunities. So that is my talk done, and I'm handing over now to Ross, who's going to talk to you about more games, perhaps.
We're gonna have a few minutes for questions and comments. And,
okay.
I'm gonna go back to just that slide just in case people have questions.
Oh yeah, It does look a little bit like if you drew it as a grid, it looks a lot like the Canadian.
So my question is, how did you manage to get integration? Because that's a very tricky part. Similar to Australia, Canada is also very siloed, but a lot of new companies making interesting new things. It's very difficult to get integration into a pharmacy management provider. So how did you manage that?
Yeah, so we're kind of lucky that we have a couple of national organisations, as well as a couple of providers for our pharmacy dispense software systems that are utilised by the majority of the community pharmacies. So the Pharmacy Guild, which is our owners organisation, they are the primary lobbying group for pharmacy in our country, and they have representation for up to 70% of pharmacies in the country. So they hold a big footprint, and so that means that from a lobbying point of view, they are able to get a consistency around a majority of pharmacies, and because they can do that, the ones that aren't members also benefit from whatever systems and structures are put in place. We also have our Pharmaceutical Society, is a national organisation with state branches, so they're both federal or federated structures. Our main dispense system is one that's utilised by, again, 60% plus of pharmacies. And so when we've been able to do these implementations, we've worked with that provider to do the module development. And then that's meant that we've been able to get a very fast uplift of pharmacies around the whole country, because we can immediately permeate, 60 plus 70% of pharmacies, and they've made it available free to any other pharmacy. And so that's, been really useful. So it makes it a lot easier, even though we've got that, cut up structure for some of the other things around our practice. At a national level, we've been able to get the software integration, the training integration. We're registered across jurisdictions. So some of the federal structure helps us in that way.
Hi, Lisa. I'm curious the extent to which, and I'm going to say the system, believes that the system is just sort of under-resourced and needs to be, so pharmacists helping in these ways is really just sustaining a good system, versus the policymakers thinking or sort of recognizing that the system actually isn't, the system itself needs to change. There needs to be a redesign, that pharmacists are not positioned correctly in a 2024 healthcare system. Where would you say policymakers or those in the system leaders are in that thought?
Yeah, at the moment there's a number of large reviews around primary care happening. So there's a 10-year plan around primary care, around like redesign of how primary care operates, to move away from, say, fee-for-service to block and blended approach, to encourage multidisciplinary teams, to use full and extended scope of practice for the healthcare team. So I think one of the primary things in response to your question is that there is a recognition that we have a really highly skilled and trained workforce, and quite a large workforce, that is using maybe 20% of what they've trained for. And that one of the key things that we should do before we make more, or we pay one group of those to do more, is lever the opportunities that might be legislative, they might be culture, they might be funding, all of those kind of things first, to better utilise our current practitioners, and then also be looking at the things around training more, looking at distribution, etc. So that's the key part. We've just finished a large piece of work around unleashing the potential of the scope of practice of our primary care workforce, including pharmacy. So it's been a big piece of the government reform policy, and they see pharmacy as a key part of the primary care workforce. Yeah.
Just have a question online from Katrina. Her question is, do pharmacists have ability to order laboratory tests to monitor the effectiveness and safety outcomes? In Canada, some professionals report this as a barrier to engaging in certain types of therapeutic areas.
Yeah, so great question. So yes and no. That's my answer. So within our scope of practice, yes. So there's nothing to stop pharmacists doing so. However, because of our funding system, they're not funded by the government. There's no rebate for the consumer if a pharmacist makes the referral. So if I referred off to a pathology place to get the test done, normally that's covered by the government if it's a referral from a doctor. But if a pharmacist does that, you would have to privately pay for that. And so that's one of those barriers I was saying, and has been identified in the work that we've done, is like pharmacists can do that, nurses can do that, a number of other health practitioners can do it, but currently it's not funded. And so it becomes an unintentional barrier to pharmacists' work and ability to do a number of activities, because people say, oh, well, you can't do that if you can't monitor the labs. So we have access to the health record for patients, which variously contains records of people's pathology, but it may be lacking the tests that's required to make a good decision about medicines. So that's why it's a yes and no. So we could order the test, but some pathology places won't accept it because it's going to impact patients because of the funding. Yeah.
So the first question is, in Canada, we have a pharmacy examining board. Is there a similar board in Australia? So I'm just wondering if in Australia you've seen any changes in the examination of pharmacists coming out of school now that you have continuing scope of practice.
Yep. So we have the Australian Pharmacy Council does the accreditation and training checks for pharmacists. So we have an internship when we finish our training. So we have to do a year in practice, and then after that we do an examination and an OSCE exam before we go into practice, and that's at the end of that period. So the national exam is twofold. So there's a written examination and an oral examination, and they manage that. As the scope changes have come in, the undergraduate courses or the training courses have had to incorporate or look at how they are delivering graduates who can meet those requirements. At the moment, you can choose, for example, not to be a vaccinator. Like, you can train in your undergraduate course to vaccinate, but nobody's going to make you do it when you get out in practice. But it's hard to get a job in primary care if you're not a vaccinator. But we do train for people in their undergrad to do that. So as these new tasks are coming in, the training authority, the council, look at the programs of study and put those into the training standards. But as we all know, and we talked about yesterday, to retask a program can take 4 or 5 years to do a full refit of a program if you make a major change to scope of practice out in the wild. So if we suddenly said all pharmacists should be graduating as full scope of practice prescribers and doing minor surgery, I think the universities would have a stroke. One of the scope of practice in North Queensland, so the Green State, is for minor surgery. So the postgraduate course has them doing suturing, and because it's quite rural, and some of the pharmacists are in places where there's no doctor, and so they've tasked them to do minor surgery. For us to retool some of our undergraduate programs to do that, it's kind of like a cannot compute, right? It's a little bit different to giving injections and taking, clinical examinations. So, yeah, that's the challenge, is, to do that. Like, we're like the Titanic, like we turn very slowly at universities. So at the moment, that's a graduate thing, right? So we're basically, it's a postgrad training program because of that. Yeah.
First of all, amazing presentation. It was really fun, and at the same time, the information are really important and crucial. So my question is, given the fact that Australia is actually a country like Canada that has a high immigration rate, do you think now with the scope getting expanded every day, there is a way to involve pharmacists who are still haven't finished their license process in some of these new rules? I'm asking this because I remember during the pandemic, physicians were given some exemptions to practice, those who haven't got the license to practice here in Canada, but pharmacists didn't get this opportunity. And they were also in the front line. They are having these contact with patients every day. So some of them were burned out, but still we weren't able to make the best use of the resources we have of this high number of pharmacists who are still doing their license process.
Yeah, so the regulations across the country allow pharmacy students to do anything that their supervisor can. So we have students in training able to vaccinate if that's the scope of their supervisor. So if they've done vax training at university, they can vaccinate. It gives us a lot of flexibility for our graduate trainees to do things that they've already trained for at university or experience out in practice, these expanded scope activities, if their supervisor has that scope of practice. So that's in our legend reg across the country, that basically an intern or a student can do what their supervisor can do. Yeah, we're very lucky like that.
That's great. I'm just going to take one question from online. Love the presentation, love the hungry hippo analogy, which I will second. The question is, can Lisa comment on whether in Australia there are pharmacy corporations where pharmacists don't have majority ownership, and how this may influence advocacy for better or worse?
No. So the ownership rule in Australia is, even though we don't have, so a pharmacist has to own a pharmacy, and they have to have the majority ownership in a pharmacy, even though your spouse or partner or significant other can also be part of an ownership structure in a pharmacy. It's complicated. This could be a whole lecture by itself, because there's obviously workarounds. People have trusts and all sorts of things. The majority of ownership, like 51% of that structure, still has to be a pharmacist as the majority owner. Even within that, the pharmacy person would have the majority ownership within those. We have kind of like a franchise oversight. So some of our big brands might be Priceline or Terry White or Chemist Warehouse, for anybody who's milled around in our literature. They're kind of like the big box style pharmacies. They call them the warehouse style. Some of Chemist Warehouse, for example, they provide like a management structure to people. So if I owned a pharmacy and Bev owned a pharmacy and we were partners in a pharmacy, we kind of buy into their management structure. And so they assist us with wholesaling, they assist us with marketing material, they would provide some of our wage and salary management, but they don't own the pharmacy. We would still own the pharmacy. Yeah. So we have kind of brands, but they wouldn't own the pharmacy. Yeah. So it's a slightly different structure. Yeah.
Any thoughts, maybe just a quick follow-up on the advocacy piece, like how that sort of plays into it?
Yeah. So that's I think why the Pharmacy Guild is such a strong advocacy group in Australia, the owners group, because they use the fact that pharmacy is an accessible health profession. And I think we talked about this yesterday, saying it's the McDonald's of healthcare, and we have to be quite careful around how that accessibility is also a tension around providing, a professional service that may take time. So they use that to say, and they have a lot of data that says people come 14, 15 times a year on average into a pharmacy. So Minister, if you kind of mess us about and you don't listen to how we're providing you feedback around how we should be involved in healthcare or whatever, we'll tell people that you suck. because we get a lot of older people that come in, we get younger people, we get mums with families, so we are a portal to the general public. And so that gives them incredible power with politicians. And so that's why the doctors hate us, because we get more access to the public in their view from a political point of view than GPs do. So a lot of people go to a GP maybe once a year, maybe twice a year, but they go to a pharmacist a lot. And so our pharmacy guild use that really effectively to get in front of politicians and say, you need to make pharmacy viable, you need to make it a profession that has good services for the community, and that's given us also a lot of opportunity. Yeah. And it's owned by pharmacists. They say a health professional is in charge of this business. Yeah.
Okay, I'll do the last question. I'm happy to do so. Lisa, I laughed a lot about you saying papers that aren't read, conferences that the people who drank the Kool-Aid come to. What has been one thing you've done to pass the successes across your siloed provinces or jurisdictions? What's been successful to go from Queensland to the next jurisdiction?
Yeah, so I think what I've, as an academic, what I've tried to balance is the what the uni needs and what the profession needs. And so, you know, I remember having conversations with my dean about this is, yeah, you do need to publish so that you can share with your colleagues, right? But then there's like cutting it so that, you know, I write for the conversation, or I would talk on the radio, or I would speak at a conference about, you know, what we did, you know, offer to speak at a conference about the outcome of the results so that the general pharmacy community can hear about it. Or I write a general news piece for the Pharmacy Journal that everybody gets when they get their membership stuff, and they can flick through it like a newsy article. It's not full of dense kind of, you know, this many results divided by this many people and this percentage and the, you know, the p-value was. It's just like, this is, you know, what's going on in the profession. So try and make it very consumable information, and then write that kind of style for a pitch piece to go when, you know, an offer to go with the guild or the PSA when they meet with the department. And so I'll come and I'll talk to them about what we're doing and why it's important. Because they're like, oh, you give me this article, but what do I need to do with it? And so, well, I'll come and talk to them about it and why it's important and why the Canadians did it and it worked, or why it's been successful and why haven't people died over there, and give them the contact to, you know, have Ross or Zubin or others, you know, come and they can talk to those people, you know. So I think that's how I've tried to do it.
Thank you. The good thing is that we get to hear from Lisa. The good thing is we'll get to hear from Lisa again. I will also just say that, just to maybe add to Lisa's answer, is that she had outcomes data to share. So I think part of the story was the data that was collected, and you were able to show uptake of the services. You were able to show outcomes that would be important to both academics but everyday people. Like we're still everyday people too when we're in academia. So I think going around and telling the story is one thing, and then having the story to tell, which was a lot of hard, good work, methodologically, is helpful too. Really my pleasure to introduce Dr. Ross Tsuyuki. He's a professor of medicine and director of the Epicor Center in the Department of Medicine, Faculty of in the Department of Medicine in the Faculty of Medicine and Dentistry, which I'm thinking is now in the Faculty of Health Sciences too, at the University of Alberta in Edmonton. He is currently you are the recent past president of Hypertension Canada, as of a few days ago, I believe. His research interests are in health services research, primarily in the area of pharmacist care for acute and chronic conditions. And I will say he is, of course, internationally well-known, renowned, and has led many of the impactful pharmacy practice research studies in Canada that we base many of our policy efforts on. And I think has really led the way in thinking about aspects of showing the effect of what pharmacists can do related to patient outcomes. So I will turn it over to you, Ross.
Well, thanks so much. It's really very much a pleasure to be here. All right. I actually don't remember why I chose this title, but I am going to talk a little bit about MedsChecks. Some of this will be an overlap from yesterday because I didn't know what anyone yesterday was going to say. I also didn't know that some of the people I was going to talk about are actually going to be here. So we'll see how that goes. That's why I'm close to the door. All right, so this is something that was talked about a little bit about yesterday, and I think it's probably been an ongoing conversation, but it's becoming more and more relevant. Why MedsChecks, or if you're from not from Ontario, medication reviews are not the solution to. Then you could say, well, if that's not the solution, well, what's the problem? But we can talk about that. I want to address a little bit sorry, it's not the OPA, it's the Ontario OCP under stress and duress report a little bit, and talk a little bit about what I think might be one of the solutions, and I'd be interested to hear what you think about it, even though it's too late to change. Okay, so just as a framework, you all know this, the MedsChecks framework was launched in 2007. Its aim was to assess, this is directly from the document, assess patients' ability to administer the medications, appropriateness of the medication, dosing, interactions, side effects, allergies, contraindications, and communication with the physician. The eligibility is currently taking three or more medications for a chronic condition, diabetes, and also long-term care. There was a set of enhancements that came into effect in 2016, which was acknowledgement of the service by the patient. Medication review was to be done on a pharmacist worksheet to sort of standardize it. The MedsCheck personal medication record and a diabetes education checklist was part of it. It was to be shared with the prescriber, and there was a follow-up component to this. So, do MedsChecks work? No, they don't. And there's evidence from not just MedsChecks, but the Alberta program has been reviewed as well, and it really doesn't have much in the way of impact. I decided to just sort of condense it into the one, and Caddis did do a review of this that I think came out, was it last year? A couple of years ago. And this is a quote from their review. So CADTH, now called the Canadian Drug Agency, in terms of patient and health system outcomes, community pharmacist-led medication reviews seem to have limited impact. Patients with chronic conditions such as hypertension or diabetes or multimorbidity seem more likely to benefit, but aren't really focused on. There's no studies of cost effectiveness, and then they started to talk a little bit about some of the barriers, like limited communication of pharmacist findings between providers, lack of time for pharmacists, does that sound familiar? And challenges with patient selection. So let me dive into that a little bit more. So yeah, what are the problems with medication reviews? So not just picking on MedsChecks, but I figure because I'm in Ontario, pick on MedsChecks. Well, it is probably the most clinically ridiculous thing to focus on the number of medications only. Like, whose idea was that? So a patient, you know that treatment of heart failure requires about 5 or 6 different drugs. So somebody on only 2 of those drugs actually doesn't qualify. So if they're not on guideline recommended therapy, you actually can't be paid to address the beta blocker that they're not on or the ACE inhibitor that they're not on. So that doesn't make any sense. Even if I wear my Hypertension Canada hat, where blood pressure control is getting worse and worse and worse, we used to be the best and now we're amongst the worst. Somebody on only one antihypertensive drug you can't be paid for that either because they're not on 3. If they were on 3, they'd probably be controlled. So that is, doesn't, as a clinician, I think that's stupid. So filter is gone. So the other problem is that the bare minimum requirement, if you really think about it, is just a medication list. That's only actually the starting point, right? It's like a bunch of physicians, you say, okay, what I'm going to pay you for and nothing else is to just do physical assessments. Don't do anything with that information. Just do the physical assessment. You can fill out a form, right? And then file it away. Nobody will see it, right? And that's it. Okay, so you do 1,000 physical assessments and it's not going to change anything, right? I'm being facetious, but that's all right. There is no guidance on which patients to select. The only guidance is pick somebody on 3 or more medications, right? You know what I think about that. There's no guidance on who to pick, where to do it, how to do it, and how to intervene either, right? So again, you might as well just do the medication history and file it away. There is, we know, very poor follow-up to these things. Well, maybe that's not so bad because if there's no interventions, what are you going to follow up anyway, right? And so we know, for example, from Laurie McCallum's work that people that get a diabetes meds check, less than 5% get any follow-up after a year, right? And so we know that that's not very good. It's not very well incentivized either. There's no supporting IT infrastructure to facilitate that communication. So what do? We fax it, and it goes into there's probably some fax heaven where all of this stuff goes, and maybe people only read it after they die. I'm not sure, but it goes somewhere or nowhere. So obviously that was one of the problems was there was no supporting infrastructure to relay this information that you've collected. And then let's open all of the cans of worms. It encourages quotas and unethical behaviors, which leads to my next piece. Okay, so you've seen this. It's been talked about already. I can't not talk about it either. And so here I thought, okay, great. I have an editorial coming out on this, and I'll give you a preview of the editorial. But what I didn't know was that it's actually already been published last week. But you probably haven't seen it, so it is still a preview. So you know that the report, there was a survey in the town halls, 70% or so experienced workplace pressures. It was worse at Loblaw, Rexall, Walmart, and Shoppers. And some of the concerns that were raised were the pervasiveness of these workplace pressures, particularly at corporate pharmacies. There's a threat to the autonomy of pharmacists. Quality of care and understaffing were issues. Well-being and burnout, which we talked about yesterday. An undermining of patient trust, that's bad, right? These are all bad things, but this is really bad because to get that back, remember, we used to always say most trusted profession? This is not good. And a perceived lack of support from regulatory bodies. And so this is not me saying this. This is the report saying this. So yeah, there's another side to this too. And you could say, yeah, but there's methodologic concerns. There's definitely a responder bias, right? Because if I say, you know what, okay, who's sad here today? The people that are sad are the ones that are going to speak up, right? And depending on how you word the question. So there's a definite responder bias. On the other hand, it's pretty hard to ignore that there was a very, very consistent message that was coming through. So yeah, you could say, no methodologies is perfect. And as was stated yesterday, this had to be done quite quickly. So I don't think I would have done any different, and I'd be subject to the same sorts of criticism. So this is the preview that is no longer a preview, unfortunately. So I wrote an editorial on this for the Canadian Pharmacist Journal. And so I thought, well, who could I talk to about this that would know something, have some opinions. And so I called up Justin Bates, who had actually never met before, but I was really happy to meet him. And we talked for 35 minutes or so. It was really good. I had a couple of structured questions, and this is just a synopsis of kind of what he told me. He said, well, he didn't like the term corporate pressure because it was kind of pejorative to begin with, and I kind of agreed with him. But pressure, we could just call it pressure, right? Because there's finger pointing. Performance metrics are needed. Businesses need performance metrics, but maybe the ones that we have now are not the right ones. And we can talk about that. He felt that absolutely no professional decision should be driven by anything but the best interests of the patient. He talked about the importance of workforce planning. We talked about that yesterday as well. And said, yeah, the whole MedsChecks process is really outdated. So, yeah, so that was interesting. I said, well, so what are you guys doing about it? And so he said, well, there's a workplace code of ethics that is coming, holding employers accountable if pharmacists' professional autonomy is threatened. And that's one thing, one lever that you could pull. The other is he shared with me some reforms to the MedsChecks programs that have been proposed, I think a couple of months ago. And it looks, from what I can see, an awful lot better, addressing some of the things that I thought were concerns about the program. All right. Then I spoke with Bev Zucker, who's sitting back there, and I didn't realize she'd be here, but this is great because you can tell me if I interpreted this correctly. From the Nova Scotia College of Pharmacists, she agreed, yeah, there is aggressive goal setting, and that, but also we both talked about this, that, but it does encourage pharmacists transition from distribution type activities to more clinical activities, and that would be probably a good thing. She noted that it wasn't just the corporate pharmacies that were doing that. Numerically, yes, probably more corporate pharmacies were doing it, but there was an awful lot of overlap. So some of the what you would call independents are actually also aggressively goal setting as well. So to Justin's point, corporate pressure maybe is not exactly the right terminology, but pressure is. And then we had some fun talking about, now I guess you had hired a business consultant, Ordonez, and there was a paper that was written called Goals Gone Wild. And if you want to scan that QR code, there's actually a one-page PDF that Bev had shared with me, and I thought it was very, very good. And actually, it's kind of funny because this is from the business literature, but it was actually using a metaphor of like the side effects, literally, it said the side effects of aggressive goal setting as if it was a drug and the unintended consequences. And so there were a number of perils that were addressed. I just picked out a couple of them. A narrow focus on just that goal. So if you say you need to do 10 MedsChecks in this shift, you'll try to do it, right? But then that's to the exclusion of everything else you probably should do, because that's what you were told you have to do. And so predictably, this can lead to a rise in unethical behavior as well, or just really bad MedsChecks, right? And we certainly saw that in Alberta, where we did a series of, as part of a PhD thesis, we did a series of interviews of people that had our equivalent of MedsChecks. And most of the patients actually didn't realize that they had ever had one. They said, no, I haven't had one of those. And yet apparently they did. So that tells you how impactful it was. And also, these kind of things lead to reduced motivation as well. All right, so I said, well, what's the Nova Scotia College doing? Sorry, if you set a numeric target for medication reviews, then pharmacists will work to that. And here are some of the other things. Ignoring the things that aren't specifically goals, but are still important. There's concerns with quality, and then, of course, staffing concerns about not having the staff to do it properly anyways. So what is the Nova Scotia College doing? They are, and this was shared yesterday, doing a staffing scorecard, which I think is going to be fascinating to see how that rolls out. And a registrar's advisory, which will state something along the lines of that, you know, we all have a responsibility for ethical behavior, and if you're being put in a situation where you can't keep up with requirements, then you need to report that. All right, so my take on this was, yeah, we have a problem, and it's pretty complicated. Managers, owners, and corporate leaders need to be aware of these goals gone wild, and need to be a lot more thoughtful in the structure and evaluation and the staffing behind these goals. Business goals and practices can never take precedence over pharmacists' autonomy and judgment. Pharmacists and owners should re-examine their codes of ethics too, because it's actually in the codes of ethics. That's one of the levers that can be used. And working conditions and pharmacists' mental health are clearly an issue and have to be addressed. And then the last thing I said was, we need to talk about this. And I actually have suggested in my editorial that CPHA needs to pull everyone together, and we need to have a summit on that quite urgently. All right, so I'm going to, in the last couple of minutes, I'm going to just tell you where we're going with this. So pharmacists, you probably don't know this, but in Alberta, there's been a huge investment in primary care clinics run by pharmacists. Shoppers is sort of leading that way with almost 100 primary care clinics that are, so they're physically within the pharmacy, but physically separate from the dispensary and separately staffed as well. And they look like a regular primary care clinic with a reception area, waiting area, and exam rooms. And so I've visited a whole bunch of these, and pharmacists are saying, we need some practical guidance for patients are coming in, and they're seeing lots of patients, like thousands of them. And there's common things that they see, and they've asked for some guidance on this. So ideally that this guidance would be evidence-based and national guidelines-based. And then we thought it should also incorporate shared decision-making with patients. So we're launching a series of 5 studies that are primary care pathways. That's what we're calling them. And basically, I'm not going to go through all the details, but basically, whatever the condition is, you're going to do an assessment. And so what do the guidelines say you should be assessing, right? And put it all up front. And so this is an electronic algorithm that is easy to follow. And you only see one, like these algorithms are huge, but you only see one piece at a time so that it's not so intimidating. There'll be red flags where you say, yeah, well, that's out of scope. And then treatment recommendations, again, by the guidelines. Integration of follow-up, like what's the recommended follow-up, and then built-in measurement of outcomes and quality indicators. And so, again, they're guidelines-based with an intuitive interface, shared decision-making, and I won't have time, but we have pop-ups that say this is a moment where you should do shared decision-making and go through the options with the patient. Facilitated follow-up visits, outcomes evaluation. We always measure clinical outcomes, quality indicators, and patient satisfaction. And then all of this, because you're clicking on things, goes into a PDF that is your documentation. So it's kind of done automatically. So I'm just going to finish. I'm going to skip all of this. You can ask about it if you want, but we are just launching 5 of these studies. And these are the 5 most common things that the pharmacists have asked us to do. So the first one is called the PROACT study. My fellow Shania Liu had presented it yesterday in a poster. It's cardiovascular risk reduction. So it's a module to make cardiovascular risk reduction a lot easier. We're doing one with knee osteoarthritis that is involving physiotherapists. That'll be kind of cool. COPD, influenza-like illness, which is going to rear its ugly head any day now, I think, probably. That's a difficult one because that's about 30 different diagnoses. And then a diabetes care pathway as well. So we think that this might actually be something that could help shape a replacement for medication review, for what we currently call medication reviews, which probably need to become more like chronic disease management. So I'll stop there and happy to answer any questions if I can. Thanks very much.
Probably don't need me to moderate either. So nothing like, we want the topic of evolving scope is large, and so thank you for broadening us even further and thinking about where we can go, what we could do. You've got
One,
someone
two.
online, right? So we'll do Alexi first and then Annalise.
So I was just.
Can you just use the mic quickly? Sorry. It's just so the audience online can hear.
Okay. So just shifting back the focus to Ontario. So if the OCP has released this corporate pressures report and the OCP wants to do something as the college for pharmacists, how can they do something against these corporations? Because these corporations have a lot of money, they have a lot of power. How can we do something?
That's a big, yeah, it's a big question, and a good one. Yeah, the corporations are big, they have a lot of money, but the regulators have a job to regulate. And the association has a job to look at job condition or working conditions and say, and so I think there are some levers to pull there. And I have informally spoken to a few of the leaders of these corporations, and they are taking this quite seriously. I don't exactly know what they're doing because they haven't told me, but they're taking this. I think you can rest assured that they are taking this quite seriously. Time will tell as to exactly what they do, though. So, good question.
I do like your business pressures. Like it's not just a corporate, it's just.
Yeah, and it's not just the corporates either, right? So again, like I was saying yesterday, I think what we got to do is try to take the high road. This is where research comes in. This is where trying new ways of doing things come in and evaluating them. It's kind of, as a researcher, that's what you can do, right? And keep talking to people about it. So I'm going to go online next.
Yeah, we have quite a few questions coming in online. This question was actually for Lisa, but
Which Lisa?
Lisa N.
Well, I'm going to change my list
Lisa
name
N,
to Lisa
Lisa
too,
D, Lisa M.
because I'm feeling kind of left out.
So the question, yeah, sort of is geared towards some of what you've talked about, Ross, as well. So Lori is asking the question online. I believe she's a family health team pharmacist, but she was saying the EMR providers, TELUS in Ontario, are now charging our family health teams for every new prescriber. So that can be, $16,000 for our family health team last year, is what she has said. Do you have a lot of pharmacists in primary care clinics, which you've talked a little bit about, but then also what are the considerations for liability insurance? Maybe we'll give this to Lisa Anna as well.
Sure. So I don't know what MR is.
EMR, sorry.
Oh, EMR. Okay. Well, I can tell you the Alberta part, right? So you are not automatically granted the ability to prescribe. You have to apply for it. Although having said that, 100% of hospital pharmacists have their prescriptive authority, and it's well over 50% of community pharmacists have that. Built into that was we had to increase our liability insurance to, I think it's a minimum $2 million. So, I mean, it cost me $110 a year to get that. And so, yeah, that's just part of it. Now, in terms of EMR, I'm not quite sure what the question was.
I think just talking about EMR providers charging for every new prescriber, which perhaps you talked a little bit about in the primary care setting as well.
I must say, I don't know about that. I know in Alberta, the direction that we're going in is we have one EMR for the entire province. Now, it hasn't rolled out to pharmacies yet. It was supposed to have, but there's still, of course, the pandemic slowed it down, and they're still rolling out to the hospitals. And primary care is not part of that either. But eventually, I'm told that it will roll out read and write access to the entire province and all healthcare providers. So, but we're not there yet.
Thanks. From an indemnity point of view, to respond to that question, we have a few indemnity providers, but the primary one that most pharmacists are covered with is the pharmacy defence. And we're covered for 20 million. So a little bit more than you, Ross. So that's the general liability for pharmacists. And so for these scope activities, we've had them as, I guess, a knowledge user through the development of the expansion of the scope. And so they've kept the people that do the actuary part of the business across, whether they felt that that was out of scope or within scope for pharmacists based on training and knowledge, and whether the additional training, say initially for VACs or what we've done with the other training programs has been in scope or needed extra liability. And at this point, for the majority of work, it's within scope. So if you have your general liability, which costs about, Bev will correct me, around $250, $300 a year, gives you $20 million in public liability cover. We have a national record as well, and so pharmacists can read from the record, and we upload dispensing data, but we can't share our clinical records with the EMR. But to cover that, we basically dispense the medicines for UTI and for vaccination. So that's how we get them into the medical record at this point in time. Yeah.
Ross, I think primary care pathways offer an opportunity, but one of the unintended consequences potentially of this is primary care is a generalist, and now you're paying people for specific slices and not a holistic view of somebody coming to your door.
Yeah. Yeah, no, I hear you. And yet, this is what the pharmacists are seeing. Like, people are coming in with these concerns. It is actually more holistic than it seems, because one of the things so people come in for different reasons. And because these clinics are often treated like walk-in clinics as well. And so they'll come in and it could be, I don't know, it could be just for a flu shot, but then they'll say, I notice you have diabetes as well. Let's talk about your diabetes, because they have actually, some of the clinics do like a 1-hour appointment, actually. And so they've got actually quite a bit of time to look into other things. So they are looking at these things. It doesn't exactly address your comment about being holistic. But having said that, there are certain target conditions that are super important and contribute to a lot to morbidity and mortality. And so you got to do something with them. So I'm hoping that we will have more of these care pathways, but we're never going to have them for every single thing. And it's not meant to replace looking at the whole patient either. So that's probably the best I can answer that. But point well taken. Yes.
Ross, I'm wondering about, because you brought up the OCP report, like the role of remuneration models. And in the same way that as scope expands and there's implementation of new services, and we talked yesterday about the challenge of doing that in the context of on a traditional dispensing system, the reality is pharmacies are still, the remuneration model is really based on payment for drug dispensing, right? So I think that is something that we don't often talk about because it's a problem that we don't have a solution for. So as researchers are developing, like yourself, are thinking about care pathways and this type of thing, I guess, what's our role in addressing the remuneration piece, which just is always kind of there, right?
Absolutely, and I think you can't ignore it. In Alberta, you can be paid for these things, though. So it's not perfect. It's far from perfect. But a lot of these things you can be paid for, and so we are encouraging people to use the existing system that we have to bill for it. It's not perfect, but what we've done is for some of the things that you can't be, for example, osteoarthritis is not, you can't be reimbursed for that. So we've actually built in to pay for it. And we're paying the physiotherapists as well, because this is a new model and we want to see if it works. So, yeah.
Hi. In case it's
Wow.
helpful. So Bev Zwicker from Nova Scotia. And in Nova Scotia, we now have 40 pharmacy primary care clinics with a similar, they're not all Shoppers Drug Mart. We've got a nice cross section and it's actually part of a study. It's under study, so it's being evaluated, which is helpful. I just wanted to flag that EMRs are a part of the structure, the infrastructure of these clinics. And my understanding is that it was part of the funding that was provided and a critical component of that team communication that's needed. So I think it's right to flag where do EMRs fit, and I think we need to have a discussion and think about how EMRs fit. But just wanted to flag, as people, as associations and others start to think about, let's explore options. Nova Scotia may have something to contribute to that conversation given their experience.
Absolutely. All right. Thank you.
Again, we'll have another chance to have conversation as well. Oops. So I'm now going to invite Yasmin and Daphne to the podium, and we are starting our set of 3 presentations that are research-focused presentations based on projects that have been funded through the NIHS, the Network for Improving Health Systems. They're in different stages. Some have gone farther yet than others because we've had 2 different funding calls, but they are all on topics that we think add some value to the consideration of the evolving scope of pharmacists. So Dr. Yasmin Abdulaziz is a current postdoctoral fellow at Leslie Down Faculty of Pharmacy, working under the mentorship of Dr. Mina Tadros, where she leads a number of health service evaluations focused on minor ailment prescribing. She obtained her PhD in 2021 from the University of Otago in New Zealand, where she led a nationwide study on the remuneration of pharmacy services. Can I say where you're going? Yes. And she is unfortunately leaving our environment soon, but that is all for good because she is going to be taking up a faculty position at the University in Canberra, and we're really excited. We're not excited. We're mixed emotions. We'll miss her, but we're excited for her. But she's in Australia, which is sort of far away, but not really because we like going there. So it's all for the good. Daphne Toe is a 2022-2023 Network for Improving Health Systems trainee, and she's completing her PhD in Health Systems Research at the Institute of Health Policy Management and Evaluation at the University of Toronto with Dr. Noah Ivers and Dr. Mina Tadros. She's also a trainee in the Office of Spread and Scale at the Women's College Hospital, the Women's College Institute for Health Systems Solutions and Virtual Care, where her work centers around developing an intervention to support community pharmacists in delivering minor ailment services more effectively. Thank you very much.
Hi, everybody. So we often talk about how excited we are and what an exciting time it is for pharmacists in Ontario because, of course, now pharmacists are getting the green light to practice to their full scope. And a recent example is the minor ailment prescribing service. But more so than that, in July of this year, it was announced that there would be more consultations looking at the addition of more approved minor ailments to the existing list of minor ailments, as well as introducing other services like pharmacists ordering lab tests and conducting more point of care testing. And we might not be at the level that Alberta is currently in, but we're certainly gaining momentum here in Ontario. But here's the thing, we are excited. But has anyone actually spoken to pharmacists working on the ground, asking them, how's it going? How do you feel about all these changes? What do you think about all these changes? Are you as excited as we are? And equally, what about the center of everything that a pharmacist does? The patient. Are these sorts of services actually helping meet their health needs? So a quick recap of what we currently know about the minor ailment services. It was introduced January 1st of 2023. Pharmacists in Ontario can prescribe for 19 approved minor ailments, and to date, we've completed over 1 million assessments across community pharmacies here. But again, little is known about the service. So here at the LDFP, we are leading a number of evaluations of the minor ailment service, and we led them from pretty much before the minor ailment service were even launched. So we've done pre-evaluations, uptake studies, we've consulted with stakeholders and policymakers about, evaluations of top priority, and finally, patient and provider experiences, which is what I want to focus on today. So I've got two main questions. We wanted to ask patients, is the service meeting your health need? And we wanted to ask pharmacists if they feel well supported, both at an individual and at a team level, to provide the minor ailment service. Two aims. What are the experiences of patients receiving minor ailments? And what are the experiences of pharmacists providing minor ailments? So we took a very qualitative approach. We decided to conduct focus groups with pharmacists and one-on-one interviews with patients. We recruited them through advertising through the Ontario Pharmacists Association, social media posts, citizens panels, and word of mouth. All our focus groups and interviews were held virtually. They were video recorded, transcribed, and the data was thematically analyzed. So what sort of questions do we actually ask our pharmacists? Well, we wanted to find out about their initial experiences and any mechanisms that they use to overcome any barriers, because we know whenever we introduce a new service in pharmacy, there's always going to be issues around increased workload, issues with workflow. So we wanted to find out from them if they feel well supported, or if there's any other sort of support mechanisms that we can put in place to help them more optimally deliver the service. We wanted to ask if it's a shared responsibility among all pharmacists that are on shift, or if there's a designated pharmacist providing this service. What about their confidence? Are they actually confident and ready if this service was to be expanded even more? And for comparison's sake, we wanted to find out if any of the pharmacists that we spoke to actually practiced in other provinces, and if there are lessons from the minor ailments and the successes of that in other provinces that we can learn from here in Ontario. In terms of our patients, we wanted to find out what reasons they chose to go to the community pharmacy and obtain this minor ailment service, how satisfied they are, and are there any ways that they feel this service can be improved to better meet their health needs. Did the minor ailment service actually resolve their query, or did they need to go to another healthcare professional for a resolution? We asked them if they would ever return to the community pharmacy to get the minor ailment service again, and if there is any area in delivery that they feel can be improved. And finally, would they even benefit from a follow-up if the pharmacist was to call them after 7 to 10 days to just check if the service that was provided actually met their health needs? So what did we find? Well, in the span of less than 2 months, we held 12 focus groups with 40 pharmacists and 35 one-on-one interviews with patients. Our pharmacists represented a range of different practice settings, and our patients represented different age groups, ethnicities, jobs, geographical areas, and types of pharmacies that they access. So for the purposes of today's talk, I'm going to give you our results in a nutshell, some high-level stuff. So our top 5 themes that came across from our pharmacist and patient discussions were as follows. In terms of our pharmacists, they spoke to factors that fed into reception of the service, not just by patients, but also by physicians. They spoke to how ready they felt when the service was being launched and even up to today, barriers to their service provision, as well as support mechanisms that were put in place and that they had to create for themselves to be able to continue providing this service. In terms of patients, they talked about accessibility, everything that fed into the idea of basically accessing the service from the pharmacy, their perceived benefits of the service, anything to do with the service process and how it was delivered, and finally, their recommended areas of improvement. Now, across both pharmacists and patients, you'll see awareness because there was a lot of discussion that despite a lot of advertising, little was actually known about the minor ailment service, and I will delve into that shortly. So, I know this is wordy, but I will guide you through it. So in terms of reception of the service, pharmacists actually said that many physicians were referring their patients to the pharmacy to get the minor ailment service for two main reasons. Number one, because the condition was perceived as minor, and number two, because patients couldn't get to see a doctor in a timely fashion. Patients were largely positive and expressed gratitude for the service. A small note, there was also a little bit of patient pushback. So in terms of provider readiness, of course, we already kind of went in knowing that there was going to be issues with workflow, staffing, we hear this all the time, but there was also lack of information clarity. So leading up to the service launch and the implementation of the service, there wasn't a lot of clear guidance on what to do. Issues with university education unfortunately also came up. So recent graduates who just entered the pharmacy workforce, especially first years, some of them didn't feel that the university education actually prepared them well enough to, offer these minor ailment services. Pharmacists did see the accessibility and the benefits of the service overall to patient health. In terms of barriers, of course, we've got our increased workload and lack of information. But surprisingly, even though education and training was made available to pharmacists, many of them commented on the fact that it was stuck behind paywalls. So they had to pay for their own education and training because in some cases employers wouldn't cover it, but also the fact that they don't get reimbursed anymore than they already do. So they don't get any extra reimbursement for providing the minor ailment service. So it seemed like a financial burden to them. In terms of supports, they said they were well supported across both the sector and pharmacy level, but there's always potential room for improvement. They implemented things like using booking systems and allocating waiting times to help control workflow and just sort of help navigate the system a bit better. The awareness piece. So I recall when I first landed in Canada in December of 2022, I would walk down the streets, there would be, a big poster on the streetcar waiting area, on the TTC, I'd switch on CP24. There was a pharmacist talking about how this service was going to be implemented and it's amazing and cool and everyone should try it out if you ever need it. But unfortunately, a lot of pharmacists said that consumer education was not achieved through those means. Not to an optimal degree. They had many patients who came in expecting that pharmacists would be able to prescribe anything under the sun, rather from a set schedule. So basically they spoke to the need for better targeting the advertisements so it doesn't fall on the pharmacist's shoulders to educate. Very briefly, because I've been given a 2-minute warning. So in terms of access, patients love the fact that they'd be able to access the service for things like minor conditions. It's convenient, it's accessible, their perceived benefits. So conditions resolved with all patients stating they were either very satisfied with the service or satisfied, and they deemed the consultation straightforward. But in terms of the process, there was actually issues around privacy because not all consultations were done in a private room, and some pharmacists, because of workflow issues, had to do it at the corner of the counter. In terms of areas of improvement, obviously expansion of the service to include more minor ailments. So patients want to see more minor ailments on that list, specifically around things like oral contraception and increasing coverage beyond those who are OHIP holders. Particularly our students who come from different provinces. And finally, again, most patients were actually aware of the service through word of mouth, not through the advertisements. Apparently they weren't well targeted. So they also had very little awareness of what conditions were actually approved. So there was a lot of patient education around that. So that's our results in a nutshell. I'm going to hand it over to Daphne.
Right. So as you heard, my PhD is around developing interventions to support community pharmacists with delivering minor ailment services. And so part of that is looking at the data to see what's currently happening right now. And so the who, what, where, and how many will be the focus of today's presentation. But I will just say that this is also very preliminary data, and so there's hopefully a lot of very exciting work coming up in the next year or so. So today we're going to answer how many minor ailment services were delivered, what did the initial uptake of these services look like, where were these services being delivered, and who was receiving these services. So we used ICES data from January 2023 to March 2024, and this represents the first 15 months of minor ailment service implementation in Ontario. As many of you know, ICES includes many health admin data sets, and so we've used 6 of them that are listed here. And we also used the newly linked data set from the Ontario College of Pharmacists, which provides us with information about the characteristics of the pharmacies and the pharmacists that are providing the service. So what did the overall uptake of minor ailment services look like? So on the horizontal axis, we have time, and on the vertical axis, the number of claims. And we can see that since January 2023, the number of claims has generally been increasing over time. This graph looks at what the uptake of specific minor ailment services was like. So again, on the horizontal axis, we have time, and on the vertical axis, the number of claims. And we can see that the number of claims for UTIs and conjunctivitis is by far the greatest compared to all other minor ailment services. And we can see that that's the trend that we've seen since the beginning of the service in January 2023. For all other minor ailments, we see fewer claims, and that's, again, pretty steady since the beginning of the service. So where were these services being delivered? So now we're looking at the pharmacy characteristics. And we can see that almost all of the services are being delivered by pharmacies that are located in urban settings. And almost, or a lot of them, are being delivered by pharmacies that employ 6 or more pharmacists and 3 or more pharmacy technicians. And what about our patients? So who is receiving these services? Similarly, most of our patients are receiving these services in urban settings, so they're living in urban settings, and they are usually 25 years of age or older and female, and we see a pretty even distribution of patients receiving these services across all neighborhood income quintiles. So the bottom line is that we see variation in the delivery of minor ailment services. We're seeing variation in the number of services that pharmacies are providing. We're seeing variation in the conditions that people are seeking care for. And we're seeing variation in the pharmacies that are actually delivering these services. So the next step, and we also heard from Yasmin that pharmacists themselves have identified barriers and challenges that they're experiencing and that they need additional supports to help them with delivering minor ailment services. And so the next step in my work is going to be trying to understand some of these factors that drive the variation that we were seeing in the data, as well as some of the barriers and enablers towards these 4 target behaviors. So these 4 target behaviors: assessing the patient, selecting the most appropriate therapy, communicating the treatment plan, rationale, and risks to the patient, and notifying the primary care provider, are behaviors that are expected of pharmacists when they're delivering these services. And this will be done through a qualitative approach where we will interview community pharmacists, and hopefully recruitment for that will start in January. And then we will use a modified Delphi approach, which will involve community pharmacists, patients, and health system leaders and decision makers to try to identify what are some of these strategies that will actually be able to support community pharmacists with the delivery of these minor ailment services, keeping in mind things like feasibility, equity, acceptability.
We're a little over time, but maybe we can see if there's one burning question, and then we will continue with our presentations. And if there's questions, you can ask them at the end. They'll be here at the end. Thank you very much. I now am pleased to ask our second presenter, Dr. Monica Agarwal, to join us. She's an assistant professor at the Dalla Lana School of Public Health at the University of Toronto. Her primary professional and research interests are health service delivery and health policy in Canada with an emphasis on primary and community-based care. She's an extremely well-known researcher and has done a huge amount of work to really help us with primary care, team-based care, health services research, and shining a light on how primary care can be organized. And she's going to share some of her thoughts today on a project that we're working on related to governance.
Hi, everyone. Yeah, thank you for having me here today. I'm really excited about telling you about a project that Lisa and I are leading with our team. It is called Informing a Governance Model for Integration of Community Pharmacists with Other Primary Care Providers in Ontario Health Teams. So I'm just going to quickly go through. I just want to be clear that the study is currently underway. We don't actually have results yet. We hope to have results in the new year. But this will give you a sense of what we're doing and how we hope it might shape policy in the future. So we'll go through a background, objectives, the research questions, some of the guiding frameworks we're using to do the study, the methodology, and the team that's behind the study. So as you know, we've been talking about this today. Community pharmacists are the first point of contact for a lot of different patients. And the context in Ontario is that there's been legislative changes that expand pharmacies' prescribing powers to 19 conditions, which essentially enables pharmacists to do work that nurse practitioners and family doctors do. So this has created a situation in which the sharing of scopes of practice for patients between pharmacies and other primary care providers like family physicians and nurse practitioners and independent organizations can lead to patients falling through the cracks. So one thing that's really important to prevent that is having effective governance models that can foster integration between independent organizations so that we can better utilize the scope of practice of our providers. So what do we mean when we're talking about governance? Well, governance is a combination of structures, policies, and processes that are often embedded in legal agreements between independent organizations. And the value of governance mechanisms is they clearly define roles, responsibilities, and accountabilities. They establish mechanisms and processes by which you can make decisions together, as well as resolve conflicts, and importantly, foster compliance with legal and ethical standards. So when we were looking at the literature to really understand what governance and integration looks like between independent organizations, we found that there's a substantial amount of research that's been done on integration of pharmacists within interprofessional teams that are primary care, but we didn't really find a lot of literature that details formal practice arrangements between independent primary care organizations like community pharmacies and teams, as well as family medicine and nurse practitioner practices, for example. So there clearly is a knowledge gap in how to create an integrated governance model between community pharmacists and teams and family physicians, nurse practitioner practices and teams. So the objective of our study is to generate evidence to inform the development of a governance model to enable better integration between community pharmacy teams and family physicians, nurse practitioners, and other organizations within Ontario health teams. So this project is really focused in on Ontario, but it obviously has relevance across the country and globally. So our research questions are, what are innovative practices for integration between community pharmacists and teams and other primary care providers and teams? So again, looking at family physician practices, nurse practitioner practices and their teams. How can governance models be structured to enhance integration between independent primary care organizations? And what are the barriers and facilitators to implementing an integrated governance model? The second framework that we're using is called the 9 Pillars of Integrated Care. So they identify 9 pillars as being essential, and we'll be looking at this as we think about governance, between independent organizations. So the 9 pillars include shared value and vision. It's the idea that you need to have a population health approach, which includes the social determinants of health, that you have to engage community partners as part of the integration, which are often organizations that are involved in the social determinants of health and delivery of that you have to include patients as partners in shared decision-making, that you need to have workforce capability and capabilities and capacity. So we talked about that a little bit today. But also the notion of training, which was brought up as well, that you need to have providers who know how to work together as well to deliver population health. Governance and leadership is really what we're focusing on, and we'll be really drilling down on what are the structures and accountabilities for different providers in this clinical relationship. And then, people mentioned it today, important things around digital solutions, having those solutions in place to be able to enable collaboration and communication, alignment of payment systems, so that, you encourage behavior that allows for collaboration and achieving those outcomes. And finally, transparency and accountability. So how are you going to go about putting in processes to see how you're doing in this integrated governance model? So what we're going to do is combine these frameworks, and it hasn't been done. So part of this study will also be testing this sort of framework. But what we'll essentially be doing is mapping out the responsibilities, accountabilities, who needs to be consulted and informed for each of these pillars. So just as an example, I'm not going to go through all of them, obviously, but just as an example for shared values and vision, we would identify within these two independent organizations or arrangements who would be responsible for developing the vision, who would be accountable for developing the vision, who would need to be consulted to develop the vision, and who would need to be informed once the vision has been developed. The study is a multi-method qualitative descriptive study design, and it's taking place in two phases. So the first phase is we're conducting a structured literature review. In our world, we call this a scoping review. And essentially what we're looking at is programs that currently exist around the world around community pharmacy and other healthcare providers such as family physicians, nurse practitioners, teams, and organizations. So that's underway, and we're hoping to have that done by the end of the year. And then the phase 2 will be to conduct interviews in Ontario with key stakeholders to guide the development of an integrated model for Ontario. So the scoping review is being informed by methodology by Joanne Briggs Institute, and we'll be using PRISMA guidelines to extract the data. Multiple databases are being used. So we are using 5 different databases to find peer review literature. We're also doing a gray literature search, looking for reports, guidelines, and policy documents, specifically focused on Australia, New Zealand, and the United Kingdom. So we're starting there because these countries are quite much more similar, and we know that there's more innovations in these countries with respect to integration. And the search strategy is being informed by our U of T information specialist. The search is being done for almost the last 15 years, so we're hoping to get information during that time period. And then the data extraction will be done using the frameworks that I talked about. Barriers and facilitators will be looking for anything around lessons learned and very specifically evidence of impact. The second phase will be interviews with family physicians, nurse practitioners, community pharmacists, patients, policymakers, and professional associations. We're essentially going to be taking some of our findings from the first phase, but integrating, the elements of the framework, innovative practices, challenges, and outcomes as part of our framing of questions. And then we will be purposely sampling, snowball sampling for about 40 people. So that should get us to theoretical saturation. And thematic analysis will be used using Braun and Clark's method to analyze the data. And then finally, we'll do a comparative analysis. So we'll look at what people are telling us that they'd like to see as part of a governance model, and then compare it to what is actually happening around the world to see how we can move things forward in Ontario. So this is our team. I just want to thank all of them for their input on this project. So Dr. Lisa Dolovich is here, Dr. Reed Bell and Dr. Yazid El Harmani are both from Alberta, and Dr. Russ Upshur are part of the team. Thank you for your time today.
Great, thanks, Monica. A topic that I often say is underexplored and underconsidered, I think, in all of the integration issues that we are faced with. I'm now very pleased to welcome Jennifer Lake to the podium. She is a pharmacist, researcher, and educator with a focus on pharmacist practice and collaboration within the primary care system. She recently started, I'll say recently, it's good, started full-time at the Leslie Dan Faculty of Pharmacy in a teaching stream role, and we are delighted that she is with us, and also has a leadership role in Temerity Faculty of Medicine. Her PhD and postdoc focused on individual role enactment in primary care, and she co-leads the project she's going to present with Sarah Allen, who is a policy researcher and the director of the North American Observatory. And we are really delighted to have you, Jen.
So thanks today for having me. I think hopefully I link a little bit of what we've heard today. So Sarah and I were lucky enough to get the grant from NIHS. Sarah is a well-known policy researcher, and I'm bringing the pharmacy lens. And so we're learning from each other with our team who's listed here between policy comparisons from Quebec and Ontario. So why we focused on this really is due to the Canadian decentralized health systems and the approaches that each province is taking to policy reforms. There's a lot of opportunities to do a comparative policy analysis and what can we learn from each other versus reinventing the wheel every time, which we do a lot. We picked Ontario and Quebec as the two largest provinces as well. Sarah and the team that I have joined have been doing work around policy analysis in primary care settings, specifically with family physicians and nurse practitioners. So we looked at how do we integrate community pharmacists into primary care teams. We are doing 3 steps, very similar to lots of other people. We did an environmental scan, we did interviews this summer. I will get to show you some of the information from there, and we will be doing a focus group this fall. So you will hear about the environmental scan and the interviews. The environmental scan, we built on some primary care work that the NAO already had, looking at pharmacists. This is a great timeline, thanks to our master's student, Isa, who did all of the hard work on the environmental scan, and Monica, who works through the NAO. And we looked really at what are the policy changes, and this is really just a snapshot of the timeline for the last 5 years. Interestingly, there's been federal changes because we've had some temporary exemptions around the controlled drugs, but normally most of the policy changes have been at the provincial levels for both. And most of the changes in the last 5 years specifically have been around scope of practice. So both provinces, but mostly Quebec, has done FMGs, which Monica and Lisa will, I'm sure, look at about their integration across some jurisdictions, so the family medicine groups. But most of it has been around scopes of practice. So in the interview portion, and this is a portion that I oversaw this summer, and I worked with Laura Brady, who is an undergraduate summer research student. The micro on the right is Laura's results. So we did interviews, very similar, semi-structured. We were targeting 10 to 12 people. We have a pretty focused question, so saturation came with 10 to 12. We are done the Ontario coding and analysis around the deductive. So one of the things that I am interested in as a pharmacist is role enactment. And we can legislate changes, and people still don't do it, and why? So I use sociologic theory around micro, individual. Why do individuals who are standing there in a spot not do what we think they should do? Yeah, it's fun. It's fun. That was what my whole PhD was on. And in this, we've used a lot of deductive framings around power. And we often think about power as being the, I'm telling you what to do. I have a student here, I tell my student what to do, right? But there's other types of power. There's macro power, so this is legitimate power. The legislative changes are an example. There's reward power. Ross spoke about remuneration
and choices and incentives. That's reward power. There's punishment power. If I am an organization and I tell you that these are the markers you need to meet, there can be punishment if you don't. So those are the higher level. That's something that I'm focusing on with Sarah, and we are looking through. But one of the things that we've noted is integration and collaboration are used very interchangeably as we talk about this. And legislation that changes a person's scope is about accessing services, but it actually doesn't make you collaborate. Legislation that integrates two professionals, like creating a family health team, may increase collaboration, but doesn't actually increase access to services unless you use that person right. And so this is something that we'll be going through. It's sort of a newer thing we're going, but as researchers and policymakers, what do we mean when we say integration? What do we mean when we say collaboration? And what are we trying to do with all of these changes? Laura Brady, who is my summer research student, she looked at micro power. And these are the individual power that we feel. And so the three things are sort of expertise power. As pharmacists, we should have an expertise. We should have a unique set that we are able to apply. There's referent power. I want to be liked by people around me. And there's information power. And so what Laura found when she went through these interviews, and if you go up the left-hand side, I will not do this as well as her, but if a pharmacist had high expertise power, they knew what they should do as a pharmacist, they were more willing to enact new roles. They would do legislated things. They would pick it up, they'd go with it. If, on the right-hand side, they had low expertise power, they most often felt very high referent power. And that was dominance of the medical profession. And Natalie spoke very well on this yesterday about physician acceptance. They just did not want to upset the apple cart. So they would not do anything, even if it was in their legislative scope. And so we found that in this groups, there were two things that sort of changed. One we kept calling small townness. If you lived in a small town, most of the time you knew everybody and you'd pick things up because it was good for the people around you. And then human health resources were both two ways. One is if you worked in a pharmacy and didn't have anybody to help back you up, you didn't have anybody to help you with the workload, you didn't do services. But if you lived in a place where there was a lot of people not doing healthcare for your community, you would pick things up. So human health resources was sort of both ways, but the people who spoke from rural areas, and we tried through our interviews to focus on both geography and types of community pharmacies. So it was really interesting to us that this individual enactment really did impact what we're seeing around service delivery. So in my 10 minutes, I wanted to talk about really, we are very privileged where we sit and we get to enact or help with policy. But what we do top down isn't always enacted by individual pharmacists. And we need to figure out how to help individual pharmacists be able to enact this in the easiest and best way for them. And there's lots of different levers here, and happy to talk about them later. But we also have to talk about, as pharmacists, and this is my pharmacist soapbox, when we talk about integration, are we talking about delivering more services in a setting, primary care, or are we talking about having specific people in primary care like us? And those are very different questions, and we will come up with very different solutions. So I'd like to thank everybody. Here is my email. Feel free to reach out if you have any questions. I'd always love to talk. Thanks so much.
Sorry, Lisa, I interrupted your lunch. I'm trying to get bites in, because I've been up here more. So there you go. Thank you so much, Jen. That's wonderful. I know we would like to have more time for questions with the speakers. They are very accessible people. If you have any questions for them after today, please do contact them. I know that they would be very happy to chat. We do, though, because of time, need to move on to the last part of our day, which is where we get to have some more discussion and a panel. So I am going to welcome again Lisa and Ross, Lisa N, back to the, I don't want to, if Lisa M was still here, I wouldn't want to put her on the spot. Back up to the front of the room. And as well, I'm going to invite two new people to join them. First, I'm going to ask Mina Tadros to come to the front. He is moderating our panel today, so I get to have a little bit more of a rest, which is good. So delighted that he will be able to do this. It's going to be fabulous. He is an assistant professor at the Leslie Down Faculty of Pharmacy at the University of Toronto and a Tier 2 Canada Research Chair in Pharmaceutical Policy and Real World Evidence. He's also the co-director of the Pharmaceutical Policy and Pharmacy Practice node at the Ontario Drug Policy Research Network and an ICS adjunct scientist. He leads research focused on real-world safety and effectiveness, improving the optimal use of medications, evaluating drug policies, and post-marketing surveillance of medications. So thank you, Mina, for moderating this panel for us. Don't start yet, because I'm going to next invite Natalie Crown, who is joining Lisa and Ross as a panel member today. Natalie is an associate professor at Teaching Stream and director of the Doctor of Pharmacy program here at the Leslie Down Faculty of Pharmacy. Her research focuses on the health workforce, particularly planning, support, and retention of pharmacy professionals. In 2023, she received a CIHR grant to investigate the expansion of the pharmacy scope of practice in Canada, which is a wonderful accomplishment, which shows she has a really great plan and is part of a network of researchers who is representing pharmacy in looking at health human resources from an academic research perspective. So thank you, Natalie, for joining this panel. And I look forward to what is going to emerge from this panel. And I will turn it over to you, Mina. Thank you.
Thank you. I have the pleasure of leading kind of a discussion here at the very end of the day. And, the purpose of this panel is to kind of round out the day, but also just to be a little bit more casual about our conversations here and have a conversation about it. There was that fad for a little bit where everything was a fireside chat and we would have like a really cheesy fireplace behind us, but we've moved away from that. Now we have panels and we can discuss these things. So I jotted down a few notes just of my thoughts around what we've been hearing this afternoon. And there's just so much happening here. But as I took a step back, one thing that we've constantly been hearing about in Canada, especially here in Ontario, and Alberta's been at it for a while, is that, people will say to me, and I received a text message from one of my physician colleagues a few weeks ago that says, boy, is pharmacy having a moment. They like to say that you're having a moment. And, it's kind of funny because for years I would go to all the pharmacy conferences and I would just get so sick of the rah-rah stuff that we kept hearing and the dream of what could be. And I maybe this is like now I'm an old man, I'd given up hope. And then all of a sudden it felt like overnight, everything sort of happened that we'd been told would come. Something like, it was almost like one of those movies like in, they prophesized the future and in came this magnificent change that happened. But, it took that drawer full of evidence like you talked about to have all of that ready. And so what I remind people about constantly is that we had to be ready for that moment. And so to kind of build on all the wonderful games that we play, it was more like musical chairs and knowing when the music was going to be turned off, that we can sit quickly on that chair and be ready. And if we didn't have all that evidence ready to point to it, I don't think we could have made an easy sell in that way. And so although it felt like we were studying ourselves for years, thinking about that way, many people in this room, our panel members here, they built such a strong foundation that we were able to leverage and point to and say that this is what really matters. And I don't think that was a fluke by any kind of time. But we are hearing this constant idea of spread and scale. And this seems to be a theme here, which is, okay, how do we go from these studies and these pilots? Now we're being called up to the big leagues and being told to do this at a system level. And that's a very big leap from a pilot study to go up to a system level and to think about that. And for a long time, Canada was known as the land of pilot studies. We loved pilot studies. And then it kind of filled up that drawer more and more and more. But how do we go from that and ensure that we have some sort of consistency? And I think that's where this idea of quality indicators and KPIs and things came up from, was to try to allow some consistency. There was also the shadow of like having businesses improve their performance and this idea of what was happening in that space. But I think it's important to remember that there's a big jump that goes from pilot study of having a few pharmacists that you can train to almost every province having something happening in that space. And how do we see ourselves being able to improve that? The corporate pressures, business pressures, pressures of what we want to talk about are constantly the elephant in the room. And this was when we were in the rooms talking about what that would look like in Ontario, was the constant thing that our colleagues would point to. They would say, you have two masters. You're a business and you're a profession, and we're not like that. And I think I really liked Ross's call to action, saying that we need to really, there's an urgency here to bring us into a room and start talking about this in a way that makes a lot more sense. And you're starting to see a lot of action in that space. And humbly, I have to admit, just like being caught off guard, I didn't think that this would be the moment. I'll admit to you guys a story I haven't told anybody yet. So in the summer, when all of this stuff was happening on the news, I get a call from the CBC. And they say, hey, there's some pharmacists talking about these, that they're being told how many MedsChecks they should do. And I said, that's not news. We've known this forever. And I actually told the reporter, like, nah, don't waste your time covering this. Like, this is a well-known secret in the pharmacy world that we have this all the time. And it was at the same time that the PPN stuff and everything was happening in this space. As you guys know, I was very wrong, very, very wrong about how the public took that on. And now in Canada, it was a moment, there's a lot of anger towards big corporations currently coming out of the pandemic, the increase of prices, but also that our physician colleagues were upset about the changes happening and the direction they were going in. And there was a conversation in a room I had with the OMA where they said, they're not listening to us, they're only listening to you pharmacy folks. And so it wasn't a surprise that it was sort of a perfect storm for us to be facing this. And I would just remind us that heavy is the crown. So suddenly we've gone from asking for change to being the change. And with that means we have to clean up shop and we have to think through what that means and how to do things better. And this is a call to action for us, right? To be thinking about how to do things better. I'm not saying it was the wrong things that were done. And I think there's some important conversations that are happening. So all in all, there's been some wonderful themes here that I think we're going to touch on. So I want to make sure we touch on spread and scale, the political winds that take us in the directions, harmonizations, but lastly, the role of academics. We are here at a university. What role should we be playing to help in this space? If we helped fill that bottom drawer, right, I keep referring back to, but now that a lot of action is happening for us here in Canada, what role do we have to bring people together, to keep filling the evidence, and to ensure that there's some sort of consistency in the practice of pharmacy? So those are kind of my overarching themes and ideas that I listen to. So with that, I'm gonna hand over. We'll start at Ross and work inwards, just some high level thoughts. And then I have some questions and conversations we can lead to and we can open up if that's okay.
How much time do we have?
Well, that's the problem. So much to cover, right?
I know. Yeah. So your questions again were consistency in practice. That was the second one.
Yeah, consistency of practice, that idea
Role
of
of
like,
academics.
yeah, and then the role of academics. But honestly, just like the things that have come up this afternoon, just high level, like what are the thoughts going through your head initially, and what kind of percolated to the top? Now that you've also got some pressure off your top.
Oh yeah, just lots. Yeah, well, I'd like to start with the role of academics. I think our work needs to be driven by our curiosity, and so that yesterday I was saying, to do what you think is the right thing to do, we should continue to do it. Yeah. And so if you think that disease X is understudied, then you should study it. And if you think it's an important problem that, let's say, pharmacists could help with, well then, yeah, you should study it. It may not be a hot topic now, but that bottom drawer needs to be filled with that. So, there's definitely a role for that. But we don't want to be tone deaf either. And so I really like the idea of partnering with our advocacy and regulatory bodies to say, well, what do you guys think? What do you guys think is hot? And why do you think that? And what can we do to help? So that's, you can't be ignorant of what's going on around you just because I'm purely a scientist, and I only do stuff that I want to do. I think we need to engage with the profession to do that. Our entire program of 5 projects that's completely come from I was super interested in these primary care clinics run by pharmacists, so I went and visited them. I didn't just invited myself and went and hung out and took pictures and asked questions. And that was the thing that they all said, love to have some guidance on what to do with this and this and this and to make it more efficient. And so it's kind of like an implementation approach. Like these are actually all things that we have evidence for, like cardiovascular risk reduction. We already did a 800 patient study, randomized trial in that, but the implementation wasn't so easy. And so if we had a tool that could help with implementing it, well, maybe that would help. And so that's why, that's being driven by, I guess, the grassroots. And that's where the idea came from, or a series of ideas. So I don't know, that's kind of the approach that we've been taking. Whether it's right or not, I don't know.
Time will tell, right?
Yeah.
That's always
It might be back.
And yeah. Awesome. Thanks. Lisa.
Yeah, I think just a couple of things to follow on from Ross. I think, research is a team sport. That's how I would see it. I think if it's practically in the environment of practice change, it's not just a team sport within our own research groups. We have to work across the disciplines, and there's been some great examples of that here, that we should be working across other health groups, but also other groups that benefit us, the econometricians, the public health people, the other disciplines who do innovation, people that do design, people that do the organizational psychology. We should be working in an interdisciplinary sense to really solve what are wicked problems. Like, it is a system issue. And so we can't imagine that one of us sitting in an office is going to fix that by ourselves. That's how we come up with these, I'm going to pull one lever and think it's going to solve a problem. It's not. These are big problems that require big teams of people to do that. So I think that's one thing. And I think by partnering and working closely with the profession and being seen as a part of the profession, often, and I said this yesterday, we as academics are sort of a tail off the end of the dog, probably a flea on the end of the tail of the dog. Sometime in the profession, I don't always sense that we're considered as the profession. We're sometimes sitting to the side of the profession. We need to be more integral in that. So we are the preferred research partner. We are the people that they come to with questions, and you've got to be there for that. I think the other thing to think about is that the profession, scope is what you're trained and competent to do, right? But everybody's scope is inside of that scope. So we go to the politicians, we go to the knowledge users, and we say, this is what a pharmacist can do, right? And so it's on TV. This is the pharmacist. We can't show you their face, but this is what one looks like. But that's the broad image of what a pharmacist is and can contribute. But as individuals, we're all different. And so, I mightn't want to vaccinate, but my friend is a vaccinator. I may be really good at cardiovascular disease, but my friend may not be, right? So when we go and have these discussions, we're talking about the rainbow kitten unicorn view of the profession and the broad indicator of what a primary care person or somebody who works in a hospital looks like. We don't expect that of our hospital colleagues. They're the ICU specialist pharmacist or right? So why are we expecting everybody to do everything at some extreme level in primary care? And then we go, hey, there's all these new things. You're going to do them all. Like that scares the crap out of people because they're like, well, I don't do that every day. I'm not managing all of these, oncology patients that are coming in, all these new patients that are now got sexual health issues. Or like, it's overwhelming for people, and we need to understand that there may be a broad journey for lots of people to come on, and that's why they're scared, right? What are they going to think of me? I've never done, sexual health before at that kind of level, and now you're asking me to do that. What are people going to think of me? I don't know. So I think we have to remember that when we talk about this is a scope for the pharmacist in primary care, sure it is for the mystical pharmacist, but all pharmacists are part of what that is, and it can vary quite widely day to day. So we have to think about that too when we're doing everything that you talked about in how we implement support and train the individual in the system to support that. And that's where we're really useful as educators and researchers in supporting that.
Yeah, and I think it's also a challenge that when we then go to those people and say, and are you confident? And are you ready? And they're like, no. And I guess not, because you've asked the question. Maybe I shouldn't be. But no, the comments that I wanted to bring are actually of those, putting my PharmD program director hat on. And you talked right at the beginning of the day, Lisa, about in Australia, 5 to 20% of health workforce people like leaving the profession for all, or leaving the workforce, for all of the reasons, age, all the other things. And, as the biggest pharmacy program here in North America, we're charged with training people to go out and be excited about entering a workforce at a really exciting time for the profession. I was also envious of your comment that you get 4 to 5 years to plan a new program, and we're doing it in a really accelerated and ambitious timeline with our PharmD program. So I was thinking a lot throughout the day about some of the themes that were arising in the different presentations and how that impacts curriculum, how that really should cause us to think really differently about how we approach what goes into the curriculum and our teaching approaches within the curriculum. And so, when we've started our conversations here, some of the things that we've talked about that I think have been reaffirmed for me today are, one of our outcomes is our graduates will be prescribers, and that's part of what they'll do. And we'll develop content within each of our courses. So that's what is happening. And then along with that comes assessment, communicating plans, diagnosis, all those elements that I saw Daphne talk about in her presentation. But then also thinking about these other constructs like collaboration, like power, hierarchy, and how do we train people to with all of those things in mind, but with a generalist lens, recognizing that we're training generalists to come into a generalist practice that can't be specialists in everything. And so how do we integrate prescribing competency frameworks, your idea of primary care pathways for certain things, but what is that? Because we have to be cognizant of overload as well. And then I thought for the graduate students in the room, wow, what a diverse array of methods that were presented today. And isn't that exciting to think about, all the way from, one-on-one interviews and focus groups, qualitative methods, to combining different frameworks, that Monica was talking about. And so that struck me as well, and how we can build that into the way we train.
So lots of different tangents we could go on.
Yeah.
Thank you for sharing your initial thoughts. So the first thing I want to touch on is this idea of consistency. And Lisa, you were talking about this a little bit about what does everybody do? I'm a bit worried, and I think some of my thoughts came from reading some of the work that came out of Alberta, where some of the patients will talk about not being able to find which pharmacies offer which service. And in Ontario, we're starting to hear a little bit of that, where sometimes they go to a place and the pharmacist will say, well, we don't do minor ailments here. And, it's like going to a physician's office and they're saying well, if they're expecting it and they think that's the baseline, it's like going to a pharmacy 10 years ago and saying, well, we don't dispense here, or going to a physician and saying, I'm not going to diagnose you here. So is there a risk if we don't have a consistency that the public won't know what we do? Or is that just overthinking it, and maybe that diversity is a good thing? And I think to your point, how do we train them up to that level that there is a consistency in that. Any thoughts on the idea of consistency that comes up sometimes?
While you're thinking, I'll start. So I think I talked about our pharmacy guild, right? And so what they have taken as an approach, and it can be a double-edged sword, but what they've taken as approach is there should be core things that you should be able to go into all pharmacies in Australia and feel that you can receive a service for. And so, for example, doing vaccination, when we were trying to get vaccination as a funded service nationally, they said you should be able to go into a community pharmacy and get a vaccination, regardless of the pharmacy. And so that was part of the agenda around getting flu vaccination across the country as fast as possible. It's going, well, Minister, you wouldn't want people in Queensland, to get it and not to be able to step over the border and get it in New South Wales. So it was about that consistent service and being able to have it available across the country in every single pharmacy, because you don't want healthcare by postcode. And that's a really big lever at home. So the risk that we now have with our minor ailments program rolling out is if you suddenly drop 23 conditions on a pharmacy, and I saw your chart and I didn't snigger in a bad way. I just went, it's not surprising that you see UTI. It's not surprising that you see the conditions that you have, with conjunctivitis, UTI, etc. Maybe you roll them out first, and then you roll out the next lot of services. And so you do them in a sequence so that you establish a set of services that people do. And we've rolled out UTI, but then Queensland went, great, you've done UTI, now you can do 23 others. And our departments come back and saying, well, all I'm seeing is impetigo, UTI, some dermatology, and they're not doing the rest. So why did we regulate for everything else? So that's the risk, right? Is that you launch out everything else and they only feel confident, competent, or are only accessed for those other services, and they pull them back out.
If you're an advocate and you're advocating, is let me just get because you're worried that if you roll one or two things out and then the momentum shifts or the next election happens, that you lose the chance to keep going. I think that's the counterfactual. Like I think that there is a risk to rolling it out and not doing it well, and that was one of my initial fears. But then there's this other side of advocacy, which is like just get everything that you can. And is that something, like how do you balance those two things, right? With like if you have momentum and the political wind shift, you might be gone.
Yeah, and I think that's you've got to kind of read the room a little bit too, right? So I think what you can see even in the data that we had for UTI is that you didn't see it, sorry, but when we rolled it out in our pilots that we then levered the evidence for, you saw that people were, probably doing about a couple of services per week on average. So it's not like they were doing heaps and heaps of services per week across the whole state. And there were a few that did a lot and a few that didn't do very many at all. And so there was a bit of, you could see the tea leaves were saying there was going to be a slower uptake of this. Right. Maybe we should get this in place, get the service model, get the software, get the funding models, get these kind of things in place, get the education and training, get people aware that you can go to pharmacy for these types of services, and then up the ante rather than just throwing them all in one go. Because it comes back to the point that you guys made. People just didn't know that that was something that you could go to pharmacy for. Yeah.
Better to nail it with like a few than 23. And it's like, yeah, exactly. Awesome. Sorry.
Yeah, I guess I'd be interested in what a regulator would say. I do believe that there's a certain core set of things that any pharmacist should be able to do. Otherwise, then they aren't competent. I guess I don't have any experience with, because we don't have a quote minor ailments program. I just hate that term, minor ailments. Yeah, common ambulatory conditions. We don't have a program like that. So, I guess we can do anything, but the way it's rolled out to us is you can do anything that you're competent in. And as a professional, you're supposed to know what those things are. And if you're deficient in an area that's, very common, like diabetes, well, then as a professional, you should be learning about it. So I guess, though, what I'm seeing is that, especially with these pharmacy care clinics, as they're calling them, you'll see a banner outside and it'll say treatment for, and it'll list them. And so there's a certain amount of competitive force there, because if that list is longer, maybe people will go there. I don't think that's been borne out yet, but I see some of them, and it's just, they just look like common ambulatory conditions to me, but some of them are much deeper than that. And so it's on the banner, that's outside the pharmacy. So maybe people are starting to get known for that. I don't know. And I have colleagues in rural areas that get people from the next town over, which is an hour away by car, and they come because they heard that this person was good with menopause symptoms or other things. And so word of mouth, I think somebody mentioned that today too, that word of mouth seems to be really, really powerful as well. But there's also this ignorance of the public's ignorance of what we can do as well. I was chasing a bus the other day, not because I was trying to catch the bus, but the government of Alberta is putting these, those ads that take up the whole bus, and it said, you have options, and it talks about, not everything needs to go to emerge, and it highlights, and one of them is you can go to a pharmacy, and it gives sort of generalities of what you can go to a pharmacy for, and so on. And I was trying to take a picture of it because it went by too quickly and I couldn't read it, and maybe that's a bad ad because it could end up in a merge. Yeah, exactly. Yeah, and you can't read it from under the bus.
Worried that someone sees that ad after safely chasing the bus, and then they go to the pharmacy, and the pharmacist is like, "Yeah, I don't do that," but the guy next door might. Like, does that affect the perception, what the public's expectations is of pharmacy?
Well, is that any different for a physician that says, I don't know how to manage that resistant hypertension, I'm going to refer you. That is part of being a professional, is knowing what your limits are. And so, yeah, I mean, if your limit is something very, very simple, well, then that tells you something too.
Yeah, and I think some of the challenges with the lists are it doesn't give the pharmacists or the professionals the ability to act upon like local community health needs. And we could argue that, like, and we saw this in some of our interview data. Yeah, it's great that I can do these things, but what I can't do is help the person that needs this, and there's no primary care in this area for diabetes, for hypertension. And so that's one of the approaches that we've been taking as we've been thinking about curriculum too, is you can't have a 2-hour lecture on all of the 19, 23, or 42 list conditions. We have to train people who have an understanding of how to assess, understand evidence-based treatment, and how to make decisions and follow up broadly, like have a common skill set around whatever we define as generalist practice. But giving people the flexibility to meet community health needs is one of the things that's important to being able to work to top to scope, and knowing who the other practitioners are in your community that also can collaborate or deliver on those services too. So, yeah.
I think you could probably also make the argument that, and I think this is kind of what you were saying, is you have to be aware of what's going on in your community. I remember when I visited the first of these pharmacist care clinics, it was in a superstore in Lethbridge, Alberta, and we flew down there. It was freezing cold at the beginning of December because I wanted to see it for myself. And so it was in a huge grocery store, and it was a physician primary care clinic, and they all left, and so they just decided to staff it with pharmacists, and that was interesting. But they didn't know what was going to walk through the door. and they were seeing 45 to 60 patients a day, 3 pharmacists, 7 days a week, right from the very beginning. And so they could not have anticipated that, well, there's a community college right next door. And so they started seeing a lot of STIs, and they didn't know that that's so they had to scramble and figure it out themselves. And then the pediatricians, I think there's only 2 pediatricians in the town, and they were seeing a lot of middle ear infections. So they started saying, go see the pharmacist instead. And so they had to literally very quickly, oh, what's the latest with middle ear infections? And they couldn't see that coming either, right? But you adapt based upon your situation, and that's what a professional does, right? And you know, we might be having coffee and saying, well, no, that's not realistic. Community pharmacists never get to have coffee, but we might be talking and say, you know what, I saw 4 people in the last hour with this, and you say, yeah, I saw that too. We said, well, we better come up with a pathway for this thing, and it'll make it easier for us as well, and make sure that I don't miss anything. So
Yeah, that's a good point about, you know, the current structures of policies don't allow adaptivity if you pick each one rather than a broad scope. Okay, I don't want to be selfish and only pick the things I want to talk about. So why don't we share the wealth a little bit? Any questions from online or in the room? Any thoughts, comments? Yeah, we got one in the back.
Hi. Hello. Okay, perfect. I just had a question regarding the primary care pathways, and comparing it to the MedsChecks. I do agree it is a better step forward. However, as you mentioned, the primary care pathways only select certain patients that are under those conditions. Also, MedsChecks provides an opportunity for probably majority of the patients in Canada who are using more than 3 medications. So how would you combat the risk of at least the MedsChecks providing a patient the opportunity to still at least access a healthcare provider, whilst the primary care pathway would just limit that opportunity?
yeah, I think that I'm not saying that it should go away completely, but maybe there needs to be different criteria. And so, you know, my 3 drugs might be different from your 3 drugs, and I might be way lower risk or way higher risk, you know, depending on what those drugs are, or based on my age or comorbidities. And so I think a lot more thought needs to go into who would really benefit from any sort of program, whatever you happen to call it. And those 5 conditions that I listed are just where we're starting from, and the intent is that we will roll them out for a lot of other conditions as well. So it's to make it easier for the most common things that are being seen right now.
2 questions.
So Lisa, you mentioned that in Australia you have a year post graduating as a pharmacy student to be able to train as a pharmacist in practice. We don't have that in Canada. So do you think that now with these new minor ailments, I guess all of you, do you think that training for pharmacists needs to change, so that it's not just in school that you're learning these things, but maybe it's something beyond that? Like I know for vaccinations, I think all the provinces, you have to do continuing education to become a vaccinator, but not necessarily for minor ailments. In Ontario, it's really just a kind of a jurisprudence kind of exam, not a clinical.
Yeah, the spoiler is that we're trying to integrate our graduate year into the program of study now. So sorry for that. So yeah, I mean, our current program, the majority of our graduates would do it in a community pharmacy, so a primary care pharmacy. A small proportion have an opportunity to do it in a hospital. So most would do that year in a primary care practice. And our educator concern with that is that that's their majority of their experiential learning, while we don't have as much experiential learning in our current program. So as opposed to your rotations that you get to do during your PharmD. Variably, people would have 100 hours to maybe 500 hours during their undergraduate program where there's structured opportunities to do different types of learning. And so the concern is that people may do, their summer vacation, their placement, and then their work experience all in the one spot. And invariably not have any great oversight or assessment or feedback on that experience. And so we want to go the other way, and we want to integrate structured various rotations and training across the whole system into our experience. So minor ailment experience, vaccination experience, acute care experience, aged care, secondary care, working in family care practice would all come into the undergraduate experience. So they would come out registered to practice, having had that. So we're looking to follow the North American and other examples. So that's the spoiler. It's just going to take us a little while to get there because we have to retool our programs.
I was just going to say that I think that's what we did, and not just us, everybody. And it was the idea of pulling the internship into the formal training program and creating structure and educational outcomes and opportunity to complete tasks and assessment and feedback across a variety of practice settings. So I think that model supports this, this type of what we're trying to achieve.
Yeah. Okay. I think, sorry, Alexa, we're going to have to close the session, but everyone who is in the room is here and can still have conversations. Of course, thank you very much, Mina, Natalie, Lisa, and Ross, for having the opportunity to be a little bit more informal in discussion and remarks and considerations. And thanks to those who provided questions to continue to feed the fuel and fire. I will let you walk to your seats. Yes, thank you, as I close things out. And I'll now take this opportunity to close the session. I think there were a number of, this was a variety of things that came up today, which is it's been really interesting, and lots of continued fuel to fuel this conversation. This is a very complex. These are very complex issues, evolving scope. Our scope in pharmacy evolving at the same time as other professions. I think some of the key questions that remain, what is the pharmacist scope in an evolving scope? What do we do and what do we not do? I have been heartened in looking at minor ailments data and knowing that not all minor ailments assessments, a goodly proportion, don't lead to a prescription, which means that pharmacists are making the call that either they refer on or they recognize that a prescription is not necessary. So I think it's important to think about, and it's come up so much today, is that evolving scope is bringing us into areas that require better thoughtful integration with the system so that we actually leverage how that scope is used. And I think also some things around who can benefit and how to best use the talents of not just pharmacy, but in collaboration with our other disciplinary colleagues. How do we really best serve people together? So there's lots to learn and still lots to do. So I want to thank everybody for thoughtful conversation about all of this. This is just a continuing conversation, but I think it's brought some really important topics to light further. I want to thank Lisa and Ross, who have come from a bit farther away to join us. Thank you. We appreciate your wise words and sharing your experiences with us and giving us a little bit of provocation along the way. That's what we need. And thank you to our oral presenters who also shared some really interesting findings and some results yet to come. And of course, to our panel who took us home in the conversation. Thank you to Annalise and Noah and our IT group for really helping us have the day, and it was so well organized and I think went so smoothly. So thank you so much for all of that. For more information about NIHS and Open, please please keep connect with us and follow up. And we appreciate everyone's participation and attendance. So I will take our leave, and I hope everyone has a good rest of the afternoon. And thanks everyone online.